My name is Jailyn Avila with the Second Shift Change podcast. This is our second episode, and I'm so excited to have our first special guests. That's Priya Ghelani and Lauren Fine. I'm so excited to have you guys here. You do such amazing work, and I've heard so much about this project. And really, this is about I want to know more. Like, I know stuff because I'm in Feminim, but I'm excited to actually be able to spend some time with you and be able to share it with everybody else because it's important work. It's why we're here. It's why we do Feminim. Priya, let's start with you. Where are you from? Where'd you do your training? And where are you working now?
Yeah, sure. I'm from Dallas, actually. I'm from North Dallas. I was born and brought up in Richardson, which is a suburb here, and going to college at UT Austin, and then medical school in Fort Worth at TCOM, and then went to residency at Jacobi Medical Center. Finished my last year as a chief resident, and then stayed on for a couple of years as faculty, and then ended up coming up to Dallas. So where I'm from with my family. So I've been there for the last few years.
Amazing. And what about you, Lauren?
I am also born and raised in Dallas, Texas. I left as soon as I could. I went to Brown for undergrad, and then I did medical school at the University of Pennsylvania. I did my emergency medicine training at Highland Hospital in Oakland, California. And then I moved back home to Dallas to be near family, and that's where I now practice.
Right on. There's always a connection with Highland, I feel like. I feel like every emergency medicine physician is like 1 degree of separation away
Yes.
from that hospital. I'm actually really good friends with Arun because,
I
we do
love
like
her.
ultrasound stuff. I love him too. He's so great. He's so good at ultrasound. He's so freaking smart and he's so nice naturally.
Love that man.
We've had a lot of good conversations in the past. I've probably known him for like 10-ish years now and he's great. But
We do a
it's nice.
podcast where we just like talk about Arun. That'd be great.
We'll do that as the bonus episode at the end of the season. We'll just talk about how much we love Arun. If you don't know Arun, he is now, I forget what actual position he has, and he's still at Highland, but he's some important person at an ultrasound company called Echo. And so it's kind of fun because he has all these like insights, and I'm a ultrasound nerd. I like love ultrasound. And so it's nice to have that and also this. Now, Dallas, is there like good place to eat that you guys would recommend? Because I've actually only ever been to Austin when I was like 20 when I was in college. So if I go back, can you guys give me like one recommendation in your cities?
Oh my God, I am incapable of doing one recommendation.
Well, we can talk about a favorite spot that we always go
How's
to.
that?
Oh,
Yeah.
that's true.
Favorite spot?
Yes.
Yeah. What's your
Okay.
favorite spot?
So we set up shop at this place called Resident Taqueria. Resident appropriate. It is in a strip mall. The chef used to be like a sewer line chef at the French Laundry, but it is a hole in the wall, really good taco place. We took our last time in a meeting there. We had a taco with fried okra, one with morel mushrooms and asparagus, one with caramelized cauliflower and kale leaves and pepitas. You get the idea. It's really good.
I think there's a direct
think
flight
you
from
can
San
do it.
Diego to there, so I will be there this afternoon.
What's-
Priya, is that like, do you agree with that? Or is there like do you
Yeah.
have a different place?
No, resident. I think it's like our favorite place. It's also close to the lake. Proximity is huge, and they have everything. They have okra. They have the best squash. They have like a watermelon salad. They have gazpacho. They have anything you can dream of.
I just feel like if you really want good Mexican food, you either come to San Diego or you go to Texas. That is from what I hear, because I haven't, as we've discovered, I don't spend a lot of time in Texas, but San Diego I know well. Lauren, when you visit, I'll text you all the good
Okay.
places to go in San Diego because we have a lot of those hole in walls that are just amazingly delicious.
I am a taco surf fan.
Yes.
That's
all right.
our go-to burrito.
I'll
You may
put it.
disagree.
You know what? I'm always down to try something I haven't tried before, and I don't think I've had that before. I don't eat a lot of seafood, but I'm
Okay.
going to. I will. I'm going to. It's happening. It's my New Year's resolution that I'm starting in June, which is when we're recording this. Now, how did you guys get involved in advocacy? Was it you got into Fem and then got these roles? Was it you were interested in this and then you got into Fem? How did we get here today?
Lauren, you want to take this one?
I was going to say, Priya, do you want to take this one? I could take it.
Alright.
I think when Dobbs happened, we pretty quickly realized that it was going to have a significant impact on emergency medical care, especially in our state. And so Priya and I both cared about those things and got together pretty early and kind of started saying, okay, what can we do? We worked on several projects improving early pregnancy loss care in our ER and trying to figure out how we offer medication management to women experiencing early pregnancy loss. And then we also worked on, okay, assuming there's going to be decreased access to reproductive care, how does emergency medicine fit in there? And so Priya and I worked on sort of onboarding our residency to the concept that we could prescribe birth control in the emergency department. And what does that look like? And sort of came up with our own quick start algorithm that we actually wrote up and published in EM News and, really worked to get our residency doing more. And sort of one thing led to another. Priya, you want to take the next step?
Yeah. So Lauren through Highland Connection, of course, had heard about Access Bridge, and we both applied to be fellows. And so we did a year as fellows through Access Bridge and a ton about early pregnancy loss, ectopic management, pregnancy at unknown location, management of all of the above. And as we all know, post Dobbs, all of this has shifted not only for elective abortion, but also for all of these conditions. And so we recognized pretty quickly and early what we were going to see in our EDs. Along that time, there were about maternal care deserts and how that was going to continue to expand in Texas. And so we decided that we really wanted to be a part of the solution and not just be bystanders. And so they were made us really energized about the work that we were doing. Worked on a few projects in terms of research and taking a look at medication management for early pregnancy loss in the ED. And that only reinforced the importance of having emergency medicine really own that this is all part of our wheelhouse. And educating our residents is a big part of that. So we're both core faculty where we are. And we recognized pretty quickly that we've all had attendings that feel more or less comfortable with things like medication management for early pregnancy loss and kind of brought all of that together. And so now we actually both hold national positions in the organization. We're implementation leaders and we work on protocols on a national level, but that's kind of how we got to where we are today.
Now, for Texas specifically, and you kind of alluded to it, why is this work so important in your state? I mean, you could argue that it's so important in the entire country, but why in your state specifically is it so important?
This is something we just can do better on a national scale. Specifically in Texas, we think there are several gaps. Number one, at least where we work, most of the women we see, and I think this is probably true again across states, that the women who seek care for vaginal bleeding in the first trimester are usually there because they don't have other access, right? They don't have an OB, it's early in pregnancy, they can't get in time. And so we really are their destination care. A lot of the time it's where we're making the diagnosis of early pregnancy loss. And they often, even if we make the diagnosis, they can't get in time to see a provider. And some preliminary data shows, right, that maternal care deserts increase in areas with care restrictions. And so we expect that to get worse. And so that's why I think we're especially concerned about this in Texas. And Texas also didn't expand Medicaid, right? So we just have a higher rate of uninsured patients who have trouble getting access to care. So it's just particularly important where we are.
Got it. Yeah, no, that makes perfect sense. Now, there are two of you. How do you guys collaborate on this massive project?
And maybe we should actually explain the massive project.
That's a great
Yeah,
idea. Let's
actually,
back up. Tell me
yeah.
about your massive project.
All right.
Um,
You want to take it?
Well, I was just going to say, I was going to add something, Jalen, about your last question about Texas. When we've been meeting these physicians across Texas, we hear about all these cases and that don't make the news, right? So there's cases that are misdiagnosed as a pregnancy at a lone location when they're actually ectopics and or ruptured ectopics. And we hear about complex cases where emergency medicine physicians don't feel comfortable managing pregnancy loss. Some ED physicians trained in departments where OB residents really managed early pregnancy loss as it came through the ED. And so they didn't really get formal education in this space. And then our friends and colleagues say, hey, we don't feel comfortable managing these cases. Like what are the updates with SB 31 and how does that affect our care? And so that's what our goal is, to really fill that gap, and not only just from the legal side, but also from the formal education side, as Lauren alluded to, because there is a gap that exists within emergency medicine from literature update in OB and ACOG and to the legal side. And so we interact with docs that trained 10, 20, 30 years ago that don't know about the updates of the discriminatory zone and how that affects their care. And it's been really cool seeing these docs say, well, I want to elevate my practice. And so can you tell us how we can do that?
To tag on to what Priya said, post Dobbs, some pretty restrictive laws became enforceable and active in Texas that took kind of the normal uncertainty around early pregnancy complications that we see in the ED and then overlaid that with the potential chance that you could go to jail for 99 years, owe $100,000 and lose your medical license, or be found civilly liable, right? So it really made people fearful. There's just injected a lot of fear and emotion into what we're doing. And you know that when you're on a busy shift and running around and 400 things are happening, the last thing you want to do is potentially run afoul of a law that's going to land you in jail for the rest of your life, right? So I think it just made people behave in a way that was more driven by fear than by science.
Yeah, I see that. I mean, naturally, all of my news feeds and my Reddit and everything, they're very focused on maternal health and all these laws that are, to say it nicely, I guess, these interesting laws. And I'll tell you, as someone that always has had an OB residency, at my beck and call, like I also am learning a lot of stuff that honestly I didn't know that we could do and we should have always been doing and we're legally allowed to do. I graduated residency in 2015, and some self-disclosure, it's taken me this long to learn that there are things that I can prescribe. I didn't know a lot of the things that I've learned listening to you guys talk, and it's been amazing, even outside of Texas, where it's one of, I think we can say it's one of the more needed places right now. But even outside of that, in California, I'm learning a lot of these things. So yes, there's older docs that have been in practice 20 and 30 years, but even someone who has been in practice post-residency 10 years, I'm still learning a lot and I still need this information because I didn't get taught it either.
And I would say I completely agree with what you're saying. And, I would say also emergency medicine has shifted, right? Of course, everyone's practice is different, but I remember docs would say, well, hey, your job is just to stabilize this patient when they come through and make sure they're not dying and then move on to the next phase. When we talk about early pregnancy loss and access to care, it's really early medication management is really important. And when we talk about things like embryonic pregnancies, a third of these patients with expectant management will be continuing to bleed by day 46, so 6.5 weeks later, if they don't have medication management. And then with missed babies, that number is a quarter. And so, and they'll want to have passive products of conception. And so, especially for EDs, where you're seeing a lot of uninsured patients and they don't have access to really good care, medication management is really important, early medication management. And so I think, we're seeing a shift to really good quality care as well in emergency medicine. And this is all kind of part of that.
So this Texas project that we've been talking about, how did it actually get started? because it's a big project, and I don't know, it just all seems kind of intimidating to me, but you guys seem like you're in it and you know exactly what you're doing, and I love that. And how did you get there?
This really began because I got to see Dara Cass in person at ASAP in 2024. And she at the time was the lead of this project of Access Bridge. And you know Dara, she just has like a million ideas and is like full of energy. And we were just talking about Access Bridge and the work. And she said, you know, wouldn't it be great if like we could do a journal club specifically about one of the Texas cases that was being carried by the Center for Reproductive Rights as an EMTALA complaint, where a woman was denied care for her ectopic pregnancy. And Dara said, sure. And I said, we can do it virtually. She was like, I'm going to come in person. I was like, okay. So Dara agreed to fly out. I was at ASAP with my PD and we just sat there and booked her flight. And in October of 24, she came to Dallas to speak to our residency. She did a lecture during our regular didactics. And then we did a journal club where Priya and I and Dara all kind of spoke about this case at a restaurant downtown. And it was a packed house. We had over 60 people. We had clinical ethics. We had OBGYN. The OB residency came. We had attendings from other local residencies and residents from other residencies all in this room to talk about this because it was so important. And it was a really energizing moment. And I think after those 24 hours where we did this talk at the restaurant and Dara spoke to the residency, I was driving her back to the place she was staying in the car and she said, what's next? And I was like, you know, after this adventure, it really seems like people need this information. Like we need this information to be able to take care of patients. And I don't know how we're going to get it to them unless we take the show on the road. And she was like, well, you want to do that? And I was like, yeah, let's take this show on the road. So that, of course, requires time and time requires money. And so we got to work basically writing a grant to see if we could get this work funded. Did anyone want to fund 2 ER doctors trying to run around the state of Texas to try to help emergency physicians be prepared to adequately take care of women with early pregnancy complications, ectopic pregnancy, previable prom, in compliance with our current Texas law? And we were super, super lucky to identify a philanthropist that was interested in that work. And we received that grant in early 2025, and we were off to the races. And that's really how it started.
So wait, hold on. So ASAP 2024, which was in September, and she came out the next month to your residency.
It was crazy. And and Dara and Priya and I were like pulling together the slides, like speaking, emailing with the Center for Reproductive Rights attorney, Molly Duane, about some additional clinical details from the case. We were, talking to everyone we could because, and just trying to pull everything together and figure out how do we even just present some of this material, right, to the residency in a state like Texas, where we really don't want to alienate people. We're really trying to help people see what our lane is and like how can we best take care of patients within our lane. So it was a fast timeline, but it is zero surprising if you know Dara.
The more I get to know her, the more that is like totally Dara.
Dara
Yes.
was a visionary, and so we've been really grateful to have us alongside us in this work.
Now, this started in March, so it's been 3 months, really, maybe a little more than 3 months at the time that we're recording this. So we're early on. What right now, 3 months in, would you guys say that you're the most proud of?
For me, when we started, I was like, all I was focused on was like, how do I get my foot in the door? There's 19 emergency residencies in Texas. And the way Priya and I initially divided the work was that I was going to do all the didactics at the residencies, and Priya has the much harder job of trying to get to every like non-academic emergency department in the state of Texas, of which there are like, how many hundred? 900?
That's many. There's a million.
A lot.
Yeah.
But there's only 19 emergency medicine residencies. But still, you know how residencies are, right? You have to identify who's the, who can you email, who's going to write you back, convince them to have this total stranger come in and teach your residents about a topic that many perceive as politically flammable. And so early on, it was just like, how do I identify the people to reach out to? How do I get them to respond to my email? How do I reassure them that the material is important and politically neutral so that they accept this? There's no precedent for this, right? And emergency medicine residencies, it's really just like your faculty teaching, your residents teaching, and maybe some consultants teaching, right? There's usually not a traveling guest speaker. So that was really interesting. And one thing that I think really helped us was we went to Cord. When was Cord? I already forgot when that was.
I
Spring.
didn't go to that one.
Okay, well, Cord, whenever you were, we were there. And we sent an email to all the program directors across Texas. And with support from our grant, we actually hosted like a happy hour. And we had residents and attending faculty come, and we just kind of pitched our work and talked about it. And people were so excited. And then we were off to the races. And so since March, I have spoken at 8 emergency medicine residencies. And I am now booked to speak at all 19 with my last one in November.
That's
So
amazing.
19 in like 9 months.
That's really good. What about you, Priya?
But, like Lauren was saying, like it is very challenging and sometimes to talk about reproductive health and early pregnancy complications. I think people are naturally nervous about the subject. They're worried as medical directors about how it's going to be perceived. And so that was probably the most challenging initially, is just saying, hey, this is a very neutral talk. It's 30 minutes, it's 7 cases, and it's real cases, that we see every day, from ectopic care to pregnancy of unknown location to sonographic findings of early pregnancy loss and what is the discriminatory zone. And then we also cover a PPROM case that's more complex at the end with the medical exceptions with SB 31. And, it was really interesting seeing kind of the shift from then to now. So at the beginning, it was a lot of medical directors who were just concerned about the perception. And now, after a couple of EMTALA complaints in Texas and an appropriate assessment of risk and interest in quality, leaders in the field in emergency medicine are like, hey, when can you come? Can you come? Could you have come yesterday? Can you talk to our OB departments? Can you tell them about our protocol? Can we utilize all your protocols? And so it's been really cool seeing that shift. And I think I'm most proud of our field, to be honest, because we have docs that have been grandfathered into the field that have been doing this work for a very long time. And then we have docs that are new out, and, some of them were trained with attendings who felt comfortable autonomously prescribing misoprostol for early pregnancy loss and not. But across the board, we've just seen a huge interest in the work we're doing. And so people recognize that this is medicine. There's nothing political of medicine and good quality care. And this is what's right for patients. And so it's been really cool watching that shift. And I've spoken at 26 EDs, community EDs. It's just, and I'm traveling to San Antonio and Corpus Christi and El Paso. We initially started our work in Dallas just because it was easier for us that way. And we know most people, honestly, in this area, and we're expanding our work to the rest of Texas. So it's been just cool seeing that shift and people being so interested in our work.
That's so brilliant. And it's work that needs to be done, and to see the reception and the enthusiasm for it, I'm sure must be energizing for you guys.
I think so. And I think that, for example, docs will come up and say, well, and then they'll email and they'll say, hey, I had an early pregnancy loss last week and I utilized medication management. And, it's just really cool to hear stories like that. And other docs in the talk that say, well, I didn't know that mifepristone could be utilized for early pregnancy loss, and the importance and the data that supports that and the need for it to be in EDs. And so that's been really cool to see as well, just the education piece and people understanding how important these medications are and how important they are in EDs and how important it is to increase access to these medications.
So we've talked about the last 3 months. We're early in the year. What do you foresee going on in the next 9 months and beyond? I know we discussed about how your guys' travel and lecture schedule is just booked now, right? Until like the end of the year, it sounds like. But past the lecturing component of it, past spreading the knowledge there in Texas, what do you think the next steps are as we continue on into this year and on to the next year?
There's a lot of next steps. I think it's really great to reach the doctors and to teach the doctors the medical side of things, but we also need to reach out to legal counsel for the various hospitals and hospital systems. So there was a article in ProPublica in the last month or two looking at maternal sepsis rates in the second trimester between Houston and Dallas, and they're really different. And that's because the hospital systems are interpreting the law differently. It's not enough to have a law. You then have to look at how people are interpreting it, and you have to reach into pretty risk averse hospital legal counsel to convince them that, yeah, this is safe and this is supported by the law and that you should do this, right? So we want to make sure that legal counsel supports our physicians and all the work they're doing so that they just feel supported. I think that's one big piece of the story. And I think another piece is research. I think there are some really big research gaps that we need to answer. I think Priya and I have both found that even though we can say, hey, this is safe, this is what family medicine does, this is what OBGYN does, the science doesn't change just because you're an emergency physician, it still feels scary to people because they haven't done it. Whether this is qualitative research around emergency physician attitudes and understanding and confidence, whether it is just emergency department centric research around return ED visits or complications after medical treatment of early pregnancy loss in an emergency department population. There's some large national data that's promising, but isn't ED specific. And so we really need some emergency department centered research to push us forward.
I think our momentum has just begun. I think that in the next 6, 12, 18 months, we're going to continue. There's so much interest across Texas that we're going to continue to be able to travel the state and talk to as many physicians as we can. We've also seen interest from groups who are leaders in emergency medicine bringing this to a national level. So I think we both anticipate that this is going to continue to expand, not only in Texas, but this is just it's gone from something that people don't want to talk about to something that people do want to talk about and recognize the utility in talking about it from a quality and risk management perspective, as well as just a great, better patient care, less return ED visits, that type of thing. And so less need to go to the OR, less return in hemorrhagic shock, that type of thing. So I think that this work will just continue to expand and that we'll just continue to see more and more interest in our work. And I'm really excited about that. I'm hoping that people continue to work on practice improvement initiatives in their own department. So we've seen some interest in that. So for example, ED docs want to adopt our protocols and they want to be ED champions in their own institutions and collaborate with OB on these protocols. And so we've seen that as well, utilizing our protocols and access bridge protocols and increasing access of mifepristone for early pregnancy loss across Texas as well. And so I think all of those are important initiatives. There's so many ways that this could go, but that are been really cool to see over the last few months what we've been able to do.
It's kind of like a train the trainer because it's the
Mhm.
perfect case scenario because the idea is that you introduce this to a hospital and there's people in the hospital that pick it up and then it just grows. And it's internally it's growing. And so it's something that they want to do because it's their patients, it's their institution, it's their family, their friends, and their neighbors specifically. And it is what we want. And it's also what's happening. And it's very exciting. So if there's individuals, there's physicians, medical providers, educators in Texas and nationally, or even, I don't know, internationally, that haven't had the wondrous opportunity to hear your guys' talk, because I've seen the lecture and it's it's very inspiring. It's very data driven. I love it. In the meantime, before you talk to everybody in the United States, because I feel like that's what's going to happen, where can people go to learn more on their own?
You can actually just go to Feminium and access all the modules that way. And so we have modules on early pregnancy loss, ectopic management, managing pregnancy at unknown location. And then for docs that feel less comfortable with mifepristone and misoprostol, it's like an introduction and a primer to these medications. And so we have all of that available through Feminium, which I have friends that work in critical access, and they say that that's really helpful for them. And there's protocols that we've worked on through Access Bridge, and also to deliver that education to ED docs across the country.
And I want to just jump on and say Access Bridge also has opportunities for interested physicians to become fellows. So they recruit a cohort of, I'm actually not sure the current numbers per year, but they're trying to get at least one physician in every state to become an Access Bridge fellow. And what that gets you is a stipend to support your time for 10 months. And it gets you individual coaching, connections to leaders in the field, and then education on these topics. And I can't recommend it highly enough. If you really want to dedicate some more of your time to this work, it's a great organization to get involved with, and you should apply to be a fellow.
On the Feminium website, there is a resources tab at feminium.org. And then for our LMS, which is free, and we also offer CME, it's courses.feminium.org, so that you can actually access what we have kind of curated for really their intros to these topics. And we are hopefully going to develop we'll call it version 2. It's not really a second version because those videos are really good. It's more just a continuation where we're going to talk about other things besides early pregnancy loss and how to prescribe Miffy and Meso in the emergency department. So it's there, it's free, and you should definitely check it out.
I've heard there's great
I just-
ultrasound education too.
It's decent. I don't know. It's mid, as my kids say. Now, when I was in residency, I didn't really learn too much about laws. I mean, I kind of did, but I kind of didn't. And my understanding of laws and how to navigate those is really based off of my own wanting to learn about these things and talking to people. Both of you seem like experts in Texas law. How did that come about?
So I don't want to fully say that we're experts, but maybe if the denominator is emergency physicians, we can take that title. I would be remiss if we did not mention how important it has been for us to work with a group of attorneys that have really spent a lot of thinking about what is the best and most expansive way to interpret the laws that we have on the books. And so we've been really lucky to work with a group called the Doctor Lawyer Alliance for Emergency Care that is looking to expand in other states, but is currently focused on really addressing the problems that patients face with early pregnancy complications in the ER. And it's brought together ourselves as Texas emergency physicians with a group of attorneys that's actually international and Texan to really equip us with the knowledge that we needed and to make sure that we are providing factually correct and legally correct information, right? So we don't want to be out there teaching people and then be like, oh, we got it wrong. So it's been really important that we've had them as experts to collaborate with. And I would say to anyone else working on state-based education, you have to find a legal champion. And similarly, I don't want to leave out our OBGYN colleagues who have made themselves incredibly available for us to bounce ideas off of, to vet the work we've been doing, and to really make sure that we're keeping patient safety at the center of everything we do.
Collaboration is key. I'm learning that a lot with Feminium. You have people that are experts in specific things, you bring them together and you're able to, it's like ingredients for a cake. Like it's not just one ingredient. Every ingredient has its own thing, adds its own flavor, and then you get a wonderful, delicious chocolate cake. It's my favorite cake. A chocolate cake of advocacy and of education, of training, and it's wonderful.
That sounds like a really delicious kit. The collaboration is key here. I think you have to just have really good relationships with the people around you who are also interested in making the world a better place and making sure that, women are not dying from early pregnancy complications and are looking to fix the increase in maternal morbidity and mortality that we're seeing.
Priya, Lauren, Dr. Ghelani, and Dr. Fine, thank you so much for taking the time out of your busy schedules and educating me on just reproductive health care, really nationally and also in Texas, and giving us the update on this amazing project that you all are just really doing such great work with.
Thank you so much for having us.
Thank you, Jailyn.
Of course.